This video presentation is about shoulder pain, how to make the diagnosis. I am Mary Lloyd, Ireland, with the Department of Orthopaedic Surgery and Sports Medicine at the University of Kentucky, and it is with pleasure that I show you these slides, many of which are cases that I've taken care of over the years in my orthopedic practice. A few cases of unusual presentations of shoulder pain. You may not have seen it, but it has seen you. So athletes are usually healthy and don't have tumors or unusual conditions, but you got to look at the x-rays clinically, examine them, listen to their history. If they look scared, then you know there may be something more than the eye meets as far as what the real problem is. So think about things you haven't seen and critically look at the x-rays and get a feel for how scared the athlete is. This is a 31-year-old lawyer, was having shoulder pain. She had had a previous x-ray a year prior to coming to see me and was treated non-operatively initially. So she came in ready for her subacromial decompression and assessment of her rotator cuff. Repeat plain x-rays every year before you're going to operate on somebody. So if you look at the x-ray on the left, there is a lucency and a widening of the coracoid. This ended up being a coracoid cartilaginous tumor, which was graded at a grade half, Chondrosarcoma of the coracoid. You can see it best on this striker view, but you can also see the radiolucency on the right on the axillary lateral view. And just pointing out the nature of the radiolucency at the base, and it just doesn't look right. So this is where you have to critically look at the x-rays, get repeat x-rays. If you have bad x-rays, get better x-rays. If you haven't an x-ray in a year, make sure you x-ray them before you operate on them, because things do change. So she underwent a coracoid resection and has done well. She would not have done well with a subacromial decompression. So she may be continuing to impinge, but remember critically looking at the x-rays, and you can see the coracoid looks more abnormal on these films, which was before her coracoid resection. She never did have a subacromial decompression. Refer her to orthopedic musculoskeletal oncologist surgeon. This is her MRI scan looked like. You can see a little better on these views. So again, there is a cartilaginous lesion occupying the entire coracoid. She might have gotten a little more symptomatic because you can see there at the tip, she might have had a little fracture through it, so had a pathologic fracture of the coracoid causing her to have increased symptoms. Grade 1, chondrosarcoma of the coracoid. Get pre-op x-rays and remember to critically look at your x-rays, particularly if you're the surgeon. This is a 12-year-old male soccer athlete. He had pain in his left shoulder for 1 to 2 years before he was dragged in by his mother to see me. No injury. Had normal stability. Critically examining him, he did have a firm, slightly tender mass in his axilla. He's right-handed. So plain x-rays were normal. These are his MR images. You can see this mass that we're feeling in his axilla is pretty big. It's anterior. This is a synovial sarcoma that would have been missed. Had a good exam, listening to the young man, and an MRI scan been done. So you can see in the lower left the glenoid, you see the labrum anteriorly, and then you see this this big synovial mass. He underwent excision of this and has done quite well postoperatively. And this is the coronal view. Other structures are normal. Large synovial mass, synovial cell sarcoma that was excised. Another view showing axial view, showing the mass. Biceps is in the right place, synovial mass. So he went a limb salvage resection followed by chemotherapy. He's doing very well. He came in to see me a couple of years later for his knee pain, which he looked at me like I was going to say it was another tumor, but fortunately it was more patellofemoral stress syndrome. But fortunately he did well from his resection of his sarcoma and axillary axilla. This is a 22-year-old whose girlfriend noticed that he had some asymmetry of his scapula. He had a history of multiple osteochondromas. Didn't really know that he had one in the scapula. X-rays show centrally in his scapula a large mass. Looks like it's been sitting there for a while, surrounding radiolucency all the way around it. Doesn't look too invasive, but it is a proximal bony lesion. You can see here circling the lesion where the lesion is. This is a true reason for scapular winging because it's a space-occupying mass. This is the outlet view on the left and the axillary lateral view on the right. You can see this that looks like bone. It's radio-opaque. You can see the distance from the ribs to the scapula on the left and understand why he is having winging, because this is a space-occupying lesion, not anything neurologic to cause winging or scapular winging that we see with shoulder intrinsic shoulder problems. So since this was axial skeleton location, proximal, he underwent a resection of the mass. It was also symptomatic. The diagnosis was osteochondroma without malignant change, and he did very well postoperatively. This is his CT scan showing the mass very well as it rotates around, so you can get a better appreciation of why he wings. He's got a large mass between his scapula and his ribs.